hit the record button. So, typically what happens is people don't even know who I am. I'm a patient. My name is Mark Rosenzweig. I was diagnosed in 2013 and been 6.5 years on lorlatinib and been very, very fortunate to, I guess, be still here. So I just turned 57. It was my birthday on June 9th. So I'm still kind of have a little hangover from that. But anyways, enough about me. So, the first thing I want to really talk about is this is a special ALKtALK for us, and the reason being is, unfortunately, Matt was diagnosed with ALK-positive lung cancer, and this is gonna be like kind of like a double ALKtALK. It'd be like almost someone explaining their field, but also diving a little bit deep into the psyche of what a doctor thinks about when he gets diagnosed with the big C. So, anyways, I'm going to pass it over to Summer real quick, and, and then you'll pass it back to me for some polling
Yeah,
questions, whatever.
we're out of
So,
practice here. We're a little rusty after like several weeks in a row. We've had a month off, and we're enjoying summer and trying to get back into the swing of things. But so great to see all of you. Thank you so much for joining us on this Sunday evening. I am Summer Farman, Mark's co-host, also a patient diagnosed in 2020, and I've been on brigatinib for about 2.5. So thanks again for joining us. We are so fortunate to have Dr. Matt Quirk here tonight. And this suggestion was actually brought to us by caregiver Megan Prose. So we're always looking for feedback on our talks. Actually, introducing ourselves was feedback that we received in the past. So we definitely value all of your opinions and want to make these programs so beneficial and informative for all of you. So Megan, who is a caregiver or wife to Eric Prose, diagnosed in late 2021, came to us with a suggestion for us to have interventional radiologist / patient, Dr. Matt Quirk, come on. So Megan, thank you so much.
Yeah, you're very welcome. I know there have been some questions on the Facebook page, and as I read through those and learned, unfortunately, about Dr. Quirk's diagnosis, I thought it would be an opportunity for patients and caregivers to get more information about that field. And as somebody that works in the medical device industry, I can help answer any technical questions you might have on some of the devices as well as best I can.
Great. I'm going to go ahead and do some polling questions real quick, and they typically, I think you guys know these by heart, but it's always interesting to figure out who's in the audience. So what is your type of treatment? Okay, I'm going to end the poll shortly. All right. As many of us already know, 66% of us have alectinib that we're taking. 16% are on lorlatinib, 8% are on brigatinib, and 4% are in chemotherapy. So I'm gonna stop sharing that one and jump into our next question, which is the length of diagnosis when you were diagnosed. And the reason I'm saying this out loud is because a recording does not pick this up. So, and I apologize because I wanted to do another polling question, but I kind of totally forgot about it. So, and as how many people know about what Matt does. So I'm gonna end this poll and share the results. So 2 to 1, basically, I'm gonna lump you guys together. That's 62% of us, and 3 to 4 is 20%. 5 to 6 is 14%. And I'm gonna stop sharing that. And I want to go ahead and introduce Matt to everyone. Just give Matt's background real quick. Matt has been with UCLA Health for 10 years. He's been 4 years as assistant professor of radiology at UCLA. He went to undergrad at Harvard, and he has his medical degree from the David Geffen School of medicine at UCLA. And like I said earlier, Matt was diagnosed in September of 2022. So I would like to introduce Matt to everyone. So Matt, if you want to unmute, say hello.
Hello. Thanks, Mark and Summer, and thanks, Megan, for suggesting this topic. I'm going to try to share my screen now to get my slides going. There. Does my slide show up?
Yes, you're looking good.
All right, great. So thanks again. It really is a pleasure and an honor to be here giving this ALK talk. When I was first diagnosed last year, I spent so much time going through the back catalog of ALK talks and listening to all the great ones from all the ALK specialists and oncologists and surgeons that have given ALK talks. But I did notice that there wasn't interventional radiology wasn't represented. And I think that, IR really does have a lot to offer for patients with ALK-positive lung cancer. So that's why I'm eager and happy to give this talk. It's not a scientific talk. I'm not really going to show you any data, but it's just hopefully going to give you a little flavor of what IR can offer to patients with ALK-positive lung cancer. So this, you've seen these memes. This is one for radiologists. So this is for general diagnostic radiologists. What my mom thinks I do is listen to patients with a stethoscope. What society thinks I do is take x-rays, which of course that's an x-ray technologist. I don't really take any x-rays myself. The ER thinks that I'm just there to give them a hard time over the phone. And the doctors on the ward think that I'm just sitting on my butt doing nothing all day. What I think I do is look at a computer and interpret images. And what I really do is probably go on Facebook and go on the ALK-positive group. So here's my take on what a radiologist does and an interventional radiologist does. And I want to distinguish that from a radiation oncologist, because those are really totally different types of doctors. So a radiologist is this guy on the top who's looking at the computer, interpreting images and writing a report about it. An interventional radiologist is these guys in the middle who are looking at images, interpreting them, and then doing something about it on the spot to do a minimally invasive procedure for the patient, whether it's a diagnostic procedure like doing a biopsy to help figure out what something is, or some kind of a therapeutic procedure. We're going to talk about a couple examples of both of those today. And then the guy on the bottom, who kind of looks like me, but that's not me. I don't know who that is. I just got that from Google. That's a radiation oncologist. So that's somebody who treats cancer by beaming in x-rays from outside the body. And this is sort of the way the pathway goes. So once you finish medical school, you would specialize either as a radiation oncologist or as a radiologist. And then once you've done radiology, you can further specialize to do interventional radiology if you want to, but they're really totally different pathways. By the way, this is all in a US context. So I'm not sure how it works in other countries, but in the US, this is how it is. And this is what I do, both of these things. I do diagnostic radiology and interventional radiology. So these are some of the tools that interventional radiology uses to do those minimally invasive medical procedures. Lots of different wires, different catheters to get different places in the body, tiny little micro catheters, biopsy devices. We're going to talk about lung biopsies in a second. We put in different types of central venous catheters. This is a hemodialysis catheter. These are ports. Some of you might have ports. They're used to infuse intravenous medicine like chemo or other kinds of medicines. Different types of central venous catheters, IVC filters, G tubes, GJ tubes, bone marrow biopsies, other different types of drainage catheters, Pleurex catheters, snares to retrieve foreign bodies from places, angioplasty balloons to open up blocked blood vessels, stents to keep them open, covered stents, different types of devices to break up blood clots and remove them from the body, and then different ways of blocking off blood vessels. So we have stuff we can inject. We have little particles we can inject. We have coils with fiber to block off blood vessels, plugs, glue. And now we have some large bore devices to suck out blood clots like pulmonary embolism or big blood clots in the large veins of the body. And what we're going to talk about a little bit later is tumor ablation. So devices to treat cancerous tumors by burning them or freezing them. And we're going to talk about a few different types of interventions that are kind of relevant to the lung. We'll talk about lung biopsy, we'll talk about thermal ablation, and a few other grab bag, different types of IR interventions. First of all, like, why would you do a lung biopsy? Why are lung biopsies important? It used to be back in the old days, like 20 years ago, before my time. It wasn't that important or they didn't really make too much distinctions. The only distinction was small cell versus non-small cell lung cancer. Then as time went by, they kind of just start distinguishing squamous cell versus adenocarcinoma. And now they know about all the different genomic drivers like us. We're this little, let's see, it's my, this off. This little lavender, I don't know if my pointer shows up, hopefully it does, but this little lavender sliver right there, that's us, ALK. Now we know about all these different genomic drivers. And that's important because that affects what treatment you're going to get. And so the only way you figure that out is by doing a biopsy. So you guys already know this, doing a biopsy is important. And it's also important at the time of progression because these pie charts are all the different types of ALK mutations that we can get that are responsible for our cancers evading therapy. And the only way you figure that out, again, is by getting tissue and doing studies on the DNA from that tumor. And so that's why doing a lung biopsy is important. But how do you get tissue? Well, there's different ways of doing a biopsy. You might have heard of an FNA or a fine needle aspiration. That's where you basically just go in with a tiny, tiny little needle and get cells from the tumor, basically. And we do that for thyroid nodules, or sometimes you can do it for a lymph node. And what we do more commonly for lung tumors or larger tumors is a core needle biopsy, where you take a little bit larger device and you take a big core from the tumor, just like an ice core if you were sampling it from Antarctica or something. And other ways of getting a biopsy is a pulmonologist might go and do a bronchoscopy to get tissue from a lymph node in the mediastinum, for example. Or a surgeon might do a biopsy and go in and take out a lymph node or take out a tumor. And what you get when you look at it under the microscope is something like this. They stain it, they do special stains so they can see what it looks like. And this would be a sample from a tumor, because you can see there's a lot of purple. When they do these stains, the cells show up purple. So this is a densely packed sample with a lot of cells. And there's some different biopsy devices that are out there. There's different shapes. They all kind of work by the same principle, though. They deploy this sharp tray into the tumor, and then there's a sheath that just kind of over sheaths it like that. It snips off a little bit of the tissue. And then you take it out of the body, and then that's your sample. And the way we do it mostly now is with this coaxial technique, where we first introduce a hollow needle right up to the tumor like this, and then the biopsy device goes through the needle. And what this allows us to do is puncture the skin just once with the hollow needle, and then the biopsy device goes in and can take multiple samples from the tumor if we need to. Here's a biopsy that was very near and dear to my heart, literally. This was a scan from a man who presented with some palpable lymph nodes in his neck and was found to have this mass in his right upper lobe and right middle lobe. So just to orient you, looking at the lungs here, this is a CT scan of the lungs. This is the right lung, this is the left lung, this is the heart in the center of the chest here. Spine, this is the back, and then this is the front. And here's my pointer's not showing up, I just realized. Here's the lung mass right here. And so this was biopsied. You can see here's the biopsy needle going right into the lung mass. The art of doing a lung biopsy is really just the art of finding a line you can draw from the skin to the target without going through any vital structures. So that's what my thought process is when I'm thinking about how to do a lung biopsy. And of course, this was my own lung biopsy, if I didn't mention that already. And this was an easy one. This was a chip shot, big mass, you know, any monkey could have done this lung biopsy, but I still asked one of my colleagues, so I know is very good at lung biopsies, to do it for me. Here's another example. Here's one I did a while back, much smaller target. Look at this tiny little nodule here. That's what I'm trying to hit. So you can see they're not all easy. And if I keep going, I'm going to miss it. So what I've got to do here is just make a little adjustment, line it up perfectly, get right on target. And then this is the picture that I take after the biopsy, which shows the smudgy stuff is a little bit of bleeding in the lung that's expected. And I actually like to see that because then it confirms I was right through the nodule when I took my biopsy. You got to just make sure you stay on target with these. Here's some more lung biopsy examples. I literally just took the last few biopsies I did. Here's one that was a nodule right along the fissure. The lung has these fissures that run through it, and this one's sitting right on one of them. And I wanted to try to avoid going through it because when you go through it with the biopsy needle, you're more likely to have air leak out of the lung and cause a pneumothorax that I'll talk about in a little bit. So found a way to avoid it. I just had to sort of skim the diaphragm right like that and point upward at it. And I was able to take that biopsy without going through it. Here is a big mass in the right lung here. Easy to biopsy, but this person also has a bunch of tiny nodules all throughout both lungs. And the situation here was she had recently diagnosed thyroid cancer. And she was found to have this lung mass. And the question was, is this metastasis from her thyroid cancer, or is this a primary lung cancer? And that was important to answer that question because it affects her treatment. So we did this biopsy, easy biopsy, and this turned out to be a primary lung cancer. This was an EGFR mutated cancer. Here's another one. Here's somebody who had his left lung removed. So you're very careful in somebody who has only one lung because that's their only lung. You don't want to mess up that lung. So I had to biopsy this other nodule that's shown up in the apex of his right lung. I was able to get there. What I had to do is there was kind of a rib in my way here. So what I had to do is kind of come from the top down a little bit and able to get that biopsy of that nodule. My point is here that, here, let me show you what can happen. So here's one I was biopsying where there's a nodule here and there's a lot of sort of cystic change around it, which that can happen with some cancers. And not surprisingly, I kind of suspected that it might happen in this case. What you can see is there's some air around the lung that has leaked out of the lung and allowed the lung to kind of partially collapse. And that's a pneumothorax. And that happens with these biopsies. It's just, even if you do everything perfectly, it just happens 5 to 10% of the time. So that's why some people don't like doing lung biopsies, because you have to deal with this pneumothorax issue. But it's no big deal because it just means you have to put in a chest tube. And some of you guys might have had these at one point or another. When I had my surgery a few months ago, I had 2 giant chest tubes in for a few days afterwards. But when I put in chest tubes, I put in tiny little chest tubes that are much less uncomfortable. It's still not the most comfortable. But what I do most of the time is manage it at home. So I'll put in the tube, I'll put on one of these little one-way Heimlich valves, they're called, and that just allows the air to escape. And if any more air leaks out of the lung, it just escapes right out the chest tube. And then I have the patient come back the next day, make sure no more air is leaking out, which usually the hole seals up, and then take the tube out the next day at home. And we looked at our numbers at UCLA recently, and our rate of putting in chest tubes is less than 2% of all of our lung biopsies, and we're managing about 90% of those at home. So we're admitting very few patients to the hospital, even if they do end up with a pneumothorax. Here's one where I had to kind of use some tricks to see where I was going. I'm trying to biopsy this mass here, sort of toward the center of the lung. And there's a lot of blood vessels around there. There's pulmonary arteries, pulmonary veins. And I didn't want to biopsy those. You stick a needle through those, it just cause a lot of bleeding and coughing up blood, and nobody really likes it. So what I did was, as I started to get close to the mass, I gave some intravenous contrast and took a CT scan. And now I can see clearly where all those blood vessels are. And I knew that if I just sort of steered clear and biopsied the edge like this, that I would be okay. And I was able to do that and get some tissue. So my point of showing you all these biopsies is kind of to say that almost everything can be biopsied. And I've heard a lot of people say, oh, you know, my tumor can't be biopsied. I was told my tumor can't be biopsied. But, you know, when I review these biopsy requests, there's very few that I think cannot be biopsied. Here's one where I was asked to biopsy this little nodule here. And this was a metastasis, suspected metastasis. And small nodule deep in the lung, sitting right next to the heart. I felt like this is a high risk biopsy, and it might be safer to just wait and observe this with a CT scan and see if it grows. And if it grows, then it gets easier to biopsy. So this is one of the very few in the 4 or 5 years I've been doing this that I actually turned down. But almost everything can be biopsied. So, you know, my recommendation is that if you're in a position where you kind of need a biopsy, you're having progression, or, you know, you need genomic studies done or something like that, and you're told that your tumor can't be biopsied, you can always ask to have it reviewed by a different interventional radiologist, somebody who does a lot of lung biopsies, and, you know, get somebody else's opinion. Just like you, if your oncologist told you something that you weren't comfortable with, you might go get a second opinion from a different oncologist. Same thing. It's a little harder because you don't, you know, most people don't have direct contact with their interventional radiologist. So you might have to kind of go through your oncologist and have them help you with that. But you can always say, hey, can somebody else review this? Is this really impossible to biopsy? Can we get a second opinion on that? There's no reason you can't do that. This is one that I declined. All right, here's another one. So here is a little nodule that was detected by lung cancer screening. And by the way, lung cancer screening is a good thing to know about. It's kind of, I mean, it's too late for us, but if you know anybody who's eligible for lung cancer screening, which is somebody who's over 50, who has more than 20 pack years of smoking, like a heavy smoker, then they should probably get a CT scan to make sure that they don't have lung cancer. It's been shown to save lives, because you can detect these little small nodules. And in this case, what was done is they did a PET CT and showed that this nodule lit up on PET. And that makes it more suspicious that it's a cancer, because it's something metabolically active. So we biopsied it, and this turned out to be a little squamous cell carcinoma. But it turned out that this patient was a little bit old, a little bit frail, not really the best person to have a big lung surgery. So it was referred to us to try to see if we could treat it in a more minimally invasive way. And we do have techniques that can do that. So this is something called ablation. In this case, we did microwave ablation. So what we do is just advance this needle that is a microwave antenna that can emit microwave energy. And just like doing a biopsy, we just advance it right up to that nodule and through the nodule. And you can see this gray stuff, that's some changes in the lung that are related to heating and ablating that nodule. And what we see over time as we follow the nodule with CT scans is we see this zone of tissue that we've cooked. We've basically burned the nodule and a little margin of the lung around it. And as we follow that over time, we see it becomes kind of less dense and collapses down. And sometimes it collapses all the way down into a little scar. Here, what happened is it sort of formed a hole in the lung, sort of a cavity. But either way, it's okay. It's taking care of that nodule, and that patient doesn't have to worry about it anymore. And this is a great way to treat tumors. You just have these microwave antenna that you stick into the body, just like doing a biopsy. And you kind of get them, you kind of want to bracket the tumor with them. Sometimes you need more than one. You can use up to 3. And they just emit microwave energy like this and create this zone of heating and cell death that can destroy the nodule, whatever you're targeting. We do it in the CT scanner right like this. Here's one of our fellows at UCLA positioning these microwave probes. We do it as an outpatient procedure, so you just would go home the same day. And for the lung, the nice thing about doing this in the lung is that the lung really doesn't feel pain. So we do it just with sedation, doesn't require general anesthesia. And we do it right in the CT scanner like this, just like doing a biopsy. And it uses this same type of energy that we're all comfortable with from reheating our leftovers. Here's another example, a little tumor in the left lower lobe here. Advanced a couple of microwave needles. And you can see these are coronal images. So like looking straight at the patient, you can see one probe going through the top of the tumor, one through the bottom. And there's this interesting phenomenon when you heat the tumor and kind of cook it, it shrinks down. You see how it's gotten smaller? This is just the same day, just minutes later. Before we cook it, after we cook it, it just gets it. What happens is it desiccates, the water in it gets converted to steam, and the whole thing just shrinks down. And you see this rim of gray, this rim of we call it ground glass, this light gray color sort of demarcates the ablation zone. And I always like to see that kind of covering the nodule and make sure I've got a nice complete ablation there. Here's another example, what we see over time. So here's the nodule ablation zone after we've treated it, shrinks into a little scar, collapses down over time. And this one just sort of collapsed all the way down into a scar. It does sort of, leave a scar. You're always going to almost always see a little scar that stays there, but we just keep watching it with CT scans to make sure that it's not growing, starting to enlarge, which would be evidence that the tumor was recurring there. We have different modalities, we call it, that we can use for ablation. So I was showing you some microwave ablations. The old school way before we had microwave was to use radio frequency. That's just sort of a different way of heating the tissue. Microwave is nice because you can create a little bit larger ablations, and it's a little bit more predictable than radio frequency. So microwave has replaced most of the old RFAs that we used to do. And then cryo, you can also kill tumors with cold. And cryoablation is something we do a lot of at UCLA as well. There's a nodule that we treated with cryoablation. Big ablation zone at first that shrinks down over time here into a little sort of linear scar. Here's one that I had to get a little tricky. There was this tumor that was kind of all the way up to the edge of the lung. You can see it's kind of touching the pleura here. And I was worried about burning the chest wall, because if I burn this tumor, it's right up against the rib. There's a lot of nerves there. I didn't really want to cause a lot of pain and burn a hole in the chest wall. So what I did was put a little bit of air into the pleural space, create a pneumothorax on purpose, separate the lung from the chest wall, and just create a little space there so I could be more comfortable burning that tumor aggressively and not causing, not burning a hole in the lung or causing a lot of pain. And, I don't want to say that everything always goes smoothly. It's minimally invasive and there's less complications in surgery, but You can certainly have complications from this, the main ones being pneumothorax. But I always expect that there's a chance of getting a pneumothorax, and I always tell everybody, there's a chance we're going to be putting in a chest tube. So everybody knows that. Other things that can happen though is you can get a pleural effusion, you can have pain after the procedure, but all the other complications are pretty infrequent. Infections and things like that are serious complications are really quite rare after these ablation procedures. Cryoablation is another way of treating tumors with cold. Turns out that if you get the cells in the tumor cold enough, it'll kill them. And you have to get them colder than 0. So just freezing into an ice cube is not cold enough. It has to be somewhere between -20 and -40 degrees Celsius to really kill the cells. So you have to get it very, very cold. But we have these cryo probes that can go in and basically freeze the tumor, create an ice cube, and kill the tumor that way. The way they do it is with this Joule-Thomson effect. If anybody knows chemistry, you probably know about it more than I do, but what happens is compressed gas gets injected into the probe and it expands in the tip of the probe because of the way it's designed, and that expansion of the compressed gas creates cold temperature by something called the Joule-Thomson effect. And with cryoprobes, you can use more than 3 sometimes. Here's one where looks like we got 4 cryoprobes going in there in the side of this patient. And here's one where we're just using 2, but you can see the frost that forms on these cables. It gets very, very cold. Here's one that was one of the more daring ones I did. It was a tumor that was growing into the heart. So this is the right atrium of this patient, and this tumor was growing right there. And the concern was that it was going to grow into the heart and start causing a lot of problems. So we were asked to see if we could do something to ablate it. So and you can see on this PET scan, this is a bright metabolically avid tumor. So I advanced a couple cryoprobes, one sort of toward the top and one toward the bottom, and froze it. And the nice thing about cryo is you can really see where the dark gray, where the gray gets darker. That's because it's less dense, and it's ice, it's frozen. The ice is less dense than water, that's why it floats. And so it looks this darker gray color. You can really see very nicely where your ablation is happening. Oops. Here, these are all from the same patient. This one patient had an issue where he kept developing lung cancers. He developed multiple lung cancers in both lungs over several years, and we did many ablations for him. My partner and I both worked on him, and we did 20 ablations for him for 20 separate lung nodules over 6 years. And this really shows the repeatability of ablation. It's not like, you couldn't undergo lung surgery 20 times. You couldn't even have SBRT or radiation treatment 20 times, no way. But ablation, each time you treat such a small area of the lung, and there's really almost no measurable decrement in your lung function. So ablation can be done again and again and again. And that's one of the main advantages that it has over other types of local treatment. And so I would say, just to kind of sum up ablation, when might you consider lung ablation? Well, there's different sort of settings where you might consider it. Stage 1 lung cancer in a patient who's not a surgical candidate. The traditional and most common way to do that, to treat that situation, is with radiation, SBRT. But ablation could be an alternative to SBRT if somebody doesn't want radiation, or they're not a good candidate for radiation for one reason or another. Another setting you might consider ablation is as local consolidation therapy for advanced lung cancer after initial systemic therapy. So I had my LCT done by surgery. Most commonly, it's probably done by radiation. But if you just have one little small, let's say you started out with a 4 centimeter mass like I did, You take your TKI for a while, it shrinks down to 1 centimeter, and then you want to do something to just consolidate that tumor and take care of it. Ablation could be an option in that setting. Probably the most common situation where we might consider ablation is as treatment for oligoprogression. So you have progression just with one little lung nodule that's growing, or one little tumor in your liver. Those can both be treated with ablation. Or if you're in a setting where you have multiple small tumors, that's another good setting where ablation can play a role too. What tumors can be treated by ablation? Well, the main limitation is size. When you start getting above about 2 centimeters, and really when you start getting above 3 centimeters, then the effectiveness of ablation is not going to be as great as other options like radiation. So the size of the tumor really is the main limitation. But you want to make sure that you're not near some critical structure. I always make sure that I'm not burning near anything that can't be burned. Like, you got to always watch out for the spinal cord, the skin, and the bowel. Those are sort of no-fly zones for ablation. And yeah, the patient has to be able to tolerate a procedure with sedation. So that this requirement, it's not as stringent as surgery because it doesn't require general anesthesia, but you have to be able to tolerate sedation, lying flat, holding your breath, and be at least in shape to do that. Here's kind of some of the relative pros and cons of different local treatment options: surgery, radiation, and ablation. And at UCLA, we have a tumor board where there's a surgeon present, a radiation oncologist, and one of us who does lung ablation, and a medical oncologist, and talking about cases. And there's sort of a multidisciplinary discussion about what type of treatment would be best for this patient. And that's really how these decisions are made best, is when everyone gets in the room together and talks about, advocates for their procedure, or says, oh, this is probably not good for my procedure, and everybody kind of compares notes on it. But I would say one of the real strong points of ablation is its repeatability. Like I kind of mentioned, you can really do it again and again and again. So if you're in the setting of having multiple small nodules, ablation is a good choice. And just to real quickly show you some other organs that we can ablate. So this is what I do actually more than lung ablation, is I kind of specialize in treating liver tumors. And this is a little tumor in the liver there. Treated this one by just sort of bracketing it with 4 little ablation needles there, and got a nice treatment zone, take care of it. And ablation is very, very effective for small liver tumors. Adrenal gland here in the left adrenal gland, that's a metastasis, a tumor that's gone to the adrenal gland. That was really the only site of disease for this patient. So we said, can we ablate it? Sure. 2 microwave probes there, sort of one on either side. Did a nice long burn and got a good ablation zone here, and took care of that tumor. And I've been following this patient for a few years now, and then no evidence of that tumor coming back. Kidney. So this is pretty good option this is a primary kidney cancer. It's not, for whatever reason, it's not common to have metastasis go to the kidney. So this is a cancer that started in the kidney, but these can be treated with ablation too. Here's 3 cryo probes just spaced around that tumor there, and there it is, took care of it. Here's one that was kind of interesting. It was this tumor that formed in the chest wall, kind of involving the rib there. And we're asked to try to treat this with ablation. And microwave, probably not a good choice here. Again, I don't like burning that close to the chest wall and the skin. But you can cryo that area. Cryo is a little less painful than microwave sometimes. So that's why I opted for that here. But I was worried about the skin. You can see how close that tumor is to the skin. So what I did in this case was I wanted to do some extra protective measures. I injected some fluid under the skin to kind of raise it up. and get it separated from the tumor. So I was able to treat it, and you can see where the ice is, this low density ice ball treating the tumor like that. I used 3 cryo probes kind of spaced through the tumor and got a good result here. It kind of flattened out and really shrunk down nicely. And I did get some inflammation in the skin, even with the protective measures that I tried to use. I got a little frostbite in the skin, and but it healed up in a couple of weeks. I felt bad about that one, but at least I treated the tumor. Here's another option. So this is not ablation. This is just kind of another procedure I do to treat tumors, but it's kind of complementary to ablation. Here was a tumor in the liver here that I couldn't really treat with ablation because it was very close to the central bile ducts. So the large central bile ducts in the liver are right here. And to burn those with a microwave really is not good because it can cause a stricture. It can really cause the bile ducts to get blocked off, and that caused a big problem for the patient. So I didn't want to do ablation, but luckily there's another procedure where you can treat this tumor with radiation. Here's an example of where I actually do a procedure that treats tumors with radiation, but it's not beamed in from the outside like a radiation oncologist would. The way we do this is by injecting radiation from the inside. We take a catheter and get up into the hepatic artery, the artery that goes to the liver, and inject these little radioactive beads that flow out into the tumor and stick in there and deliver their radiation over course of a couple of weeks. And they really kill the tumor very selectively and very nicely. It almost looks like an ablation. It just leaves a hole in the liver like that. And that's called Y90 radioembolization. That's another procedure that I do a lot of to treat liver tumors. It's very effective. And I think that's it. Yep, that's it. That's me and my wife Karen at our older son's 7th birthday party the other day. And then those are my 2 sons at their school's hoedown in their straw hats. So you get kind of an idea of the energy level we're dealing with at our house. I don't know if you can hear them in the background. A few minutes ago, they were screaming and playing. But that's kind of it. That's all that I had. You know, I'm happy to have more discussion and answer any questions you guys have. Thanks for listening.
First of all, I want to say you have adorable kids, and thanks for showing them to us, because it brings a more personal flavor to the ALKtALK. Can you stop sharing your screen, and we'll get into some Q&A.
Yeah.
All right. So you did mention something that's kind of interesting, is you have been following a lot of our Facebook postings, and the role of ablation in the TKIs. So do you typically, as a doctor, do you see this shrinkage of the TKI, then you go into some LCT therapy? So you can explain to everyone what you mean by LCT.
Yeah, so LCT is local consolidative therapy. And what that means is doing some kind of local treatment, meaning treatment of a tumor, surgery, radiation, or ablation, after you've gotten an initial response to a systemic medication like a TKI or chemo. It's the same sort of principle. So the idea is you start a TKI, you get the response to the TKI, like almost everybody gets a nice initial shrinkage of their tumor. And then once you've gotten that level of shrinkage and initial response, then you do some local treatment to consolidate the response. They kind of borrow the word consolidation from the way they treat like leukemia and different types of cancers. They'll do an initial induction chemo that gets the response, and then consolidation chemo to really consolidate, solidify the response. They borrow that word to use in this context. But basically, it just means doing surgery or radiation or ablation on your tumor after you've gotten an initial response to TKI.
Okay, so just to line up the questions and get everyone in the same framework. So LCT, we're stage 4, we going from the tumor board. After maybe 2 months, we get scanned, and then we have to plan what's next, typically. So your role on the tumor board as a interventional radiologist, how do you think your role is against, I think we all know what radiation oncology does. You know, a lot of us probably have been radiated, but not that many of us have had interventional radiologies. So can you answer why not? I mean, you know, is it because of the size of the tumor that we don't see you typically?
Yeah, I honestly, I think the main reason is that these therapies I've described, they're not yet widely available.
Mm.
I would say most major academic centers will have some degree of availability of lung ablation, but outside of major academic centers, they're few and far between. And radiation oncology really has much more established role in most community centers.
Okay,
So,
so that goes to my next question, which is the cause and effect of the pros and cons of doing what you do versus being radiated. So there was a question in there about, you know, proton therapies and SBRT and the side effects of radiation versus there is no side effects of what you're doing, correct?
well, you know, it's all relative. So what I'm doing is a minimally invasive procedure, but it's still an invasive procedure. There's a needle that goes in your body. There's some upfront initial risk of pneumothorax and some less common risks from the procedure. So, you know, that's you weigh those risks in one hand versus a radiation treatment. There's nothing that goes in your body. It's completely non-invasive. You just lay on the table and they shoot x-rays at you. So there's really no risk, no upfront risk at the time of the procedure. Doesn't mean it's risk-free. So there's still, you can get things like radiation pneumonitis, radiation esophagitis. I know there's members that have experienced those things. And so you really want to push your radiation oncologist to say it's different for everybody because it depends where your tumor is, how much radiation you're getting, what is the dose to the esophagus. And so you want to really make sure you're clear on what the risk of all those things is and that you're comfortable with it.
So you know where we typically get our metastasis, and can you go back? There was a question in here about can the ablation be used for your primary tumor? So my assumption is, I guess you shrink it down. Could you hit your primary tumor with ablation?
Yeah, definitely. If it's, you know, if it's of a reasonable size and an accessible location, which most are, then you definitely can treat the primary tumor with ablation.
Okay, so what is the difference if my primary tumor shrinks after the original TKI, and then you typically go to radiotherapy of some sort, my assumption. When would you advocate as a patient to talk to and get ablation versus typical radiation?
Well, if it's a small tumor and
Define
it's,
that, please.
I would say ablation really is most effective for 2 centimeters and under.
Which is
So-
not that small, to be honest with you. You know,
Yeah, you know, it's all relative. My tumor was 4 centimeters when I was diagnosed, but then, you know, after I was on the TKI for about, I was diagnosed in September of last year, and I took my TKI for about 4 months before I had surgery. And my last scan before I had surgery, it shrank down to just under 2. It was like 1.9. So yeah, it could have been treated. My primary tumor could have been treated with ablation if I had wanted to go that route. But this thing about surgery is you can also do a mediastinal lymph node dissection, which was also done to get some of my mediastinal lymph nodes out. You can't really do that there's no way you don't really ablate mediastinal lymph nodes. It's pretty hard.
So I know that you kind of covered it in your presentation, but there is a question here in regards to what are the other areas of the body that you typically would have your services? The liver, you
Liver is a
said.
common one. You can do adrenal glands. You can do bones. So you can do bone ablation. It's another area where radiation is more common, but for a small bone lesion, or sometimes we do it for palliative reasons. If there's a painful bone lesion, cryoablation can be quite effective in relieving the pain, and it kind of works a little bit faster than radiation. So we do a fair amount of palliative bone ablation too. We don't really ablate the brain, and we don't.
That was my next question, because there is a question about the brain.
Yeah, they do actually. There's neurosurgeons who do a version of ablation in the brain. You can use like fiber optic lasers to basically do the equivalent of an ablation in the brain, but that's outside my scope.
Okay. There's Megan. I think you put something in the chat. Do you want to unmute and tell us what you meant by all that?
I was attempting to answer a question here. It might have gone slightly about my bounds of being technical in nature, but just trying to describe the difference between external radiation therapy or stereotactic and the ablation procedure. And so I was just describing the fact that with ablation, you've got a needle that's inserted into the tumor directly. That energy is coming out of the tip of the needle versus the equipment that you're otherwise in from a photon or proton beam standpoint. That's, the beam is coming and the energy is coming from that machine outside of your body and inside it. But feel free to correct me where I'm wrong, Dr. Quirk.
No, that's exactly right. And sometimes people ask about photons versus protons. They're the same thing. They're external radiation that's beamed in. The difference is protons are larger, heavier particles than photons, and the radiation oncologist can use that, take advantage of that to sculpt the dose a little more. And sometimes you can get your dose a little more targeted with protons. So it's more focused in where it's supposed to be instead of spreading out into the adjacent tissues. It depends on exactly where the tumor is and how they do their radiation plan, but sometimes protons are a little more targeted.
And how about the airway? Can you do it in the airways?
Ablation?
Yeah, that's one of the questions.
Yeah, you can. If you're near a large airway, I try to stick to cryo, because with microwave you can burn holes in the airway. That's not so good. So if I'm near a large central airway, I'll stick to cryo. But then the issue with that is you have more bleeding with cryo. So we have had issues of bleeding into the airway afterwards. So sometimes you have to be careful, but you can work around the airways most of the time.
And when you were talking about biopsies, you said most things can be biopsied. And you show us a slide, and I'm busy with the controls, so I kind of caught some of it. But are you talking more of like a core biopsy? Is that what you're referring to?
Yeah, core biopsy. Almost all areas of the lung can be biopsied. And there are very few nodules that can't be.
And what is the tissue that you need for the core? Because I've been through a lot of core biopsies where it's necrotic tissue if it was radiated before, or it's not enough tissue for the actual biopsy. So how do you know that you got enough tissue?
Yeah, that's a good question. And partly it's experience. I know, if I know that a sample is going to be sent for NGS, for example, I'll always use a larger gauge device, so I get larger cores, and I'll take as many as I can. And I think in my experience, not all interventional radiologists are sensitive to that issue. They think, I'll just get one good core, 1 or 2 good cores. That should be enough to make the diagnosis. And it may be to just say, yeah, this is a lung cancer, but it's not enough to do all the molecular studies that need to be done. So, that's why if you're at it's good to be part of a program where people are used to doing biopsies for lung cancer and they know the need to get adequate tissue. And that issue of getting a necrotic sample comes up sometimes if, for example, a tumor has been irradiated, and there's concern that maybe it's recurring and you want to biopsy it. You have to make sure that you go after the part that is actually growing, that looks like new tumor, and not the part that looks like dead radiated tumor. And sometimes you have to kind of use a PET scan to guide you, try to go toward the area that's more active on the PET scan, because it's more likely to give you a usable sample. Those are the
It's
kinds
just-
of the things that are nuances.
Then the other thing that I don't think a lot of people realize is contrast. A lot of us maybe have an allergic reaction to it, or we don't like it. So how does that, if you don't do contrast, is that a big factor?
No, I don't use contrast for 98% of my lung biopsies because you can see the lung nodule perfectly well. The air in the lung kind of provides a natural contrast against the dense nodule. So you see nodules in the lung quite well without contrast. But that one example I showed was just one where I wanted to see the blood vessels in the lung even better than I usually do. So that's why I gave contrast in that case. But usually you don't need it.
Okay, and there's a question here, can a biopsy and microablation be done at the same time?
Yeah, yes, definitely. And that we've been asked to do that more often lately. But that's another example of ablation. One advantage ablation might have over radiation, because when you're doing radiation, you don't get any tissue for pathological analysis. But if you're doing an ablation, you have the option of doing a biopsy at the same time. And then at least you've got a sample before the nodule is treated that you can send.
I have a friend of mine who wrote this. I'm going to butcher the word probably, but she had a occipital laser ablation in the brain. OCCIPITAL. Do you know what that is?
Occipital? Okay.
Yeah. So explain that to the audience.
I think that was that laser ablation that I was referring to. Neurosurgeons do it. They basically use a stereotactic frame, and they, I don't know that much about it, but I think they insert a little fiber optic ablation device into the brain and ablate brain tumors that way. It's a way of treating brain tumors.
Okay, here's another one. We're going to keep you here all night, by the way. So hopefully your kids.
I got nowhere to go. The
You're on
kids are
Pacific
just playing in the
Coast time, right?
backyard.
It's only 5 o'clock there, so you have plenty of time. Sorry. How long do you suggest to wait after starting a TKA to think about ablation for residual tumor?
Well, if you're thinking about LCT, there's different thoughts about when to do LCT. There's the thought of wait until, I would say probably the most common thought is wait until you've got the maximal response to the TKI, meaning everything's shrunk as much as it's going to shrink. And that, I think usually is somewhere in the 3 to 6 month range. There's also the thought of, no, do it earlier, because the earlier you do it, then it has less chance to, the whole idea of doing LCT is to get rid of any persister cells that are remaining there so they don't have a chance to mutate and cause progression. So the idea of doing it earlier would be to just get them out of there earlier before they have a chance to be exposed to the TKI and start mutating. And nobody knows which of those ideas is right. They haven't really been subjected to a test that compares one to the other. So it's kind of just whatever makes sense to you and your oncologist.
And,
I wanted
another,
to jump in. Can I
Yeah,
just
sure.
add on to that quick? So you talked about with LCT or any ablation, there being a maximum tumor size to then you'd switch to just straight radiation. How about a minimum tumor size? Like when there's only 3 millimeters, it might be ground glass opacity. They're not really sure, but you want to zap it with something. Do you need to have something to stick that needle into? Is there a minimal size?
There's not a minimal size as far as technical feasibility.
Mhm.
If you can see it on a CT scan, you can go after it. Sometimes I've biopsied like 5 millimeter nodules.
Yeah.
And I think I've been asked to biopsy even smaller nodules, or I've been asked whether it's feasible. And like when you start talking about 4-3 millimeter nodules, it's like the yield of trying to biopsy that, it's more likely than not that I'll miss it.
But
So,
how about to do the ablation, not to biopsy it?
yeah, right. To do an ablation is a different story, actually, because there you don't need to be perfect.
Right.
You don't need to be millimeter precision. You just need to be in the general area. So I would say there's really no minimal size. If you can see it on a CT scan, you can probably go after it with ablation.
Okay, great. Mark.
Oh, sorry, I'm back. This is a question where it's a long question, but I should read it. Currently, my husband's large liver tumor is 4 centimeters and is near bowel. He also had a second tumor that is smaller. Last week, his radiation oncologist discussed possible palliative radiation to shrink the tumor, then embolization and or ablation. Radiation oncologist is reaching out to experience IR in Santa Fe, UC Health, and possible UCLA, where I think he did have this training years ago. Have you seen palliative radiation as a first step when it's near the bowel, and then embolization, ablation? Did you follow that?
So yeah, I think I understood there's a two tumors in the liver. There's a large one that's near the bowel, and the concern is they're considering palliative radiation to be followed by ablation. I would say if I'm not familiar with ablation followed by or radiation followed by ablation. I think, you know, either way you would aim for a definitive treatment of the tumor. I'll just give you my opinion on treating the liver, and this really only applies to the liver. You know, the normal liver is very, very sensitive to radiation, and has been in the past a limitation to treating liver tumors with external beam radiation. And now they're doing very targeted SBRT, and I have seen some liver tumors treated with external beam radiation, but it leaves a big hole in the liver. It damages a lot of normal liver. And I think it's treating the liver with external beam radiation, you have to be very careful. Our liver tumor board, most tumors in the liver are directed toward IR for either ablation for small tumors or Y90 for larger tumors.
So that brings us to a question here about the brain again. Can you use Y90 in the brain for one or multiple lesions?
Y90 cannot be used in the brain yet. We're looking into, well, there is a interest in doing Y90 for brain tumors, but it's not approved yet, and it's not even investigational yet, but there is a trial for that starting up.
Okay, I have some personal questions, and I know you and I kind of went back and forth with some emails, but when did the doctor hat pop on your head after you got diagnosed? I'm sure you, like us, you had the same grief and, you know, what the hell. But then when did you stick your hat on as a doctor and start digging deep into your disease?
All throughout. I mean, my wife and I are both doctors, and you know, after I was diagnosed, I think we all had this. There was, you know, the moments that really stick out in my mind are when I found out that I had a lung mass, because I knew I presented with just, I felt lymph nodes in my neck. That's how I presented. And I'll just tell you my little story. I felt lymph nodes in my neck, and I went to work and I took an ultrasound myself, and I just stuck it on there. And they look like malignant lymph nodes. So I know what those look like. I see them all the time. So I was like, what's going on? And then I just had my colleague biopsy them like the next day. And I didn't have the results because it takes a few days to kind of get the results back. And I went and got a CT scan in the meantime. And it showed that I had a big lung mass and a bunch of mediastinal lymph nodes and cervical lymph nodes. And as soon as I saw it, immediately, I'm a radiologist, so as soon as I saw the images, I knew that I either had lung cancer. My first thought was, I have lung cancer. And then I calmed myself down. I was like, I'm a 38-year-old man. it's unlikely that I have lung cancer. I've never smoked a cigarette in my life. I probably have lymphoma. I kind of convinced myself that I had lymphoma. And I even called and I was talking to the lymphoma oncologist at UCLA, whom I knew. And I was like, I think I have lymphoma. And I'll never forget this. He goes, yeah, Matt, I think you have lymphoma. And I told him, my first thought was I had lung cancer. And he goes, Matt, why would you think that? The chance of you having lung cancer is less than 1%.
Mhm.
And, I really wanted to have lymphoma because that's, it's very you get chemo and it's cured most of the time. If you have the most common type of lymphoma. And then I found out that I had lung cancer a few days later. That lymphoma oncologist called me on the phone and told me, we got the pathology back and you have lung cancer. And I was by myself at home and I really just broke down. I think everybody's been through something like this. Because I knew what that meant. I knew if I have metastatic lung cancer, that's not curable.
Mhm.
And I didn't know, I kind of knew, I'm not a medical oncologist. I don't specialize in lung cancer, although I do a lot of lung biopsies. And I kind of, I had heard of EGFR. I think I had heard of ALK, but I didn't really know that much about it. I didn't know that it was different from regular lung cancer. And I didn't know all that stuff. So I basically thought I was looking at a year or two of chemotherapy and that was going to be it.
Mhm.
And I think we all had that little period, and I had a period too. It was really, really, it was tough. And but my wife and I think that's when we started our doctor thing. We started kind of every night we were going on PubMed and looking up medical articles and kind of researching.
But you did not
different
know you had
treatments.
lung cancer though until did it take you 2 weeks also to find out? Like most of us, or
About
did you
ALK?
find out? Yeah, did you find out earlier that you had ALK?
Yeah, actually, I found out because I had a lung, and after the neck biopsy, I had a lung biopsy.
Mhm.
And at UCLA, we do IHC, we do immunohistochemistry for ALK, and that only takes a couple days. So, I found out within less than a week, I would say, that I had ALK. And my oncologist told me. I didn't know right away, like what good news that was, but then I
Right.
figured it out. And but even so, it was a whole process of, that's when I was going through and looking through all those old ALKtALKs,
Mhm.
reading tons of articles. Every night we were just up on PubMed. I mean, we're not oncologists, but we know how to read medical literature. So we were spending a lot of time, reading papers and deciding. We learned about LCT, figured out that's what we want to do, kind of
Mhm.
like, that's kind of what the process was. And we've all been through a different version of that. For us, it involved reading a lot of medical articles.
And one last question. How long did it take you to get involved in ALK positive? And what's your thought of the people who are in those medical committees with you?
Oh, ALK-positive is an amazing organization. It's incredible that this organization exists that's made up of patients who are have just become organized enough to raise money to fund research for their own disease in a meaningful way. There's like no, and it's for this relatively uncommon type of lung cancer. I mean, there's like other examples of that. There's like breast cancer organizations and these,
Mhm.
things where they're much more common diseases, but to have an organization like ALK-positive that actually does the kind of work it does, and it's the model for all the other targeted groups. They all want to be like ALK-positive because we're so organized and really ahead of the game.
Yeah, it's
And
amazing.
yeah, it's ALK-positive is a really inspiring organization. But yeah, it took a few months for me to actually kind of get involved. At first, I was just involved with the Facebook group. Then I kind of reached out to Colin, and he introduced me to Ken Culver. And now I've been kind of meeting with the CTC, the Clinical Trials Committee, and trying to get involved in that way.
And I'm going to lead it to the last statement, which is the more you get involved in this group, it doesn't matter what you do, it just gives you a purpose. And the more purpose you have, the easier this disease is. So I really definitely, I appreciate this ALKtALK, and did a fantastic job. And it's amazing to meet you finally versus just texting back and emailing back and forth. So thank you so much. And Summer, do you have any final words?
I'm pretty much speechless. This has been unbelievable. Yeah, we're so grateful. This is, yes, you're a wealth of knowledge, Matt, and I'm so sorry that you have ended up here with us, but we are so grateful to have you and fortunate as part of the family. So thank you. I'm sure you'll be inundated really on Facebook now with even more questions, you know, hitting you up on Scamxiety and everything else. So thank you so much. And Megan, thank you for bringing Matt to us.
I don't think I can take credit for that, but yes, appreciate the talk.
Okay, everyone, you can unmute and send your love to Matt.
Thanks, Matt, and
Okay.
good luck on your
Thank
journey
you.
also.
Thank
Thank
you.
Thank you, Matt.
Thank you.
Thank you, Matt. Thank you, Mark.
Thanks, Matt.
Thank you, Summer. Thank you,
Thank
Megan.
you.
Thank you.
Okay, we'll see everyone probably in September because we're done for the rest of the year.
No, wait, we do have one more coming up,
That's the summit one
the summit pregame. So stay
Right,
tuned. Stay tuned.
for those who are going to the summit. All right, take care, everyone. Thanks again, Matt and Megan. See ya
Thank
in
you. Have a
summer.
great night, everybody.
Thank you.
Bye.
Thanks, Summer.